Welcome to the first podcast on Resuscitation Concepts I. The objectives of this podcast are to review the physiology and the basic principles of advanced cardiac life support. The primary reference for this topic is Chapter 55 in Morgan and McHale's Clinical Anesthesiology. That chapter is essentially a review of the 2010 guidelines for cardiopulmonary resuscitation published in Circulation. It would be well worth your time to read many parts of this, and perhaps beginning with the executive summary, which should give you an overview of the topic. The guidelines are an international consensus of 356 experts from 29 countries. In 2010, there was a significant change in philosophy regarding airway breathing and compressions, such that ABC has changed to CAB, placing compressions or external cardiac compression at a higher priority than airway or breathing, at least for adults and for children and infants. There is also emphasis on high quality CPR, specifically meaning the depth of compressions, the rate of compressions, the attention to a recoil of the chest wall, performing intubation in less than 10 seconds, maintaining a diastolic arterial pressure of at least 20 millimeters of mercury, and when possible, measurement of central venous saturation in excess of 30%. There is also emphasis on early activation of the emergency response system, the use of hands-only CPR, and early defibrillation. There is also de-emphasis on feeling for a pulse. The text of the guidelines summarizes the difficulty that bystanders and even medical personnel have with feeling for a pulse. Sometimes venous pulses are felt and lead to the wrong conclusion as to whether or not there's been return of spontaneous circulation. A second reference for you would be Chapter 97 in Miller's textbook. In my opinion, this is a very good reference, well written and well illustrated. The authors are Roger D. White. He is a co-author of the 2010 guidelines and is a prolific writer. Many publications eventually are found to have an error or two within the original publication, and this screenshot shows that there's an erratum published for this article, which is simply the omission of the word initial when referring to the recommended energy dose. Nonetheless, it is worthwhile reviewing the most recent iteration of any published guidelines. The first objective of this podcast is to review the physiology. The physiology of closed chest compressions can be explained by the theories of cardiac pump versus thoracic pump. This slide, which is from Miller, provides cartoons of both mechanisms of circulation. The cardiac compression pump is pretty straightforward in that with competent valves, the cardiac chambers are compressed within the thorax between the sternum and the spine, and blood is pumped from the left ventricle into the arterial circulation. There is scientific support for each of these two mechanisms and theories, and over time it has appeared to evolve that the cardiac pump may well be operative in the early parts of resuscitation, and as the heart becomes less compliant, the thoracic pump theory becomes more operative. There also may be differences between patients with respect to the chest wall compliance and lung compliance and such. Suffice it to say that forward flow and circulation is a function of compliance of the heart and the ability of chest compressions to transmit blood through the pulmonary circulation and to ultimately to the arterial circulation. The basic principles of ACLS can be summarized as time being of the essence, quality of the resuscitative efforts does affect outcome, and the evidence from scientific study does support the current algorithms and protocols. Beginning with Airway, it is now recommended that the airway be assessed after initiation of external cardiac compressions. The first maneuver should consist of a head tilt or jaw thrust with appropriate cervical spine precautions. Any foreign body or vomitus is removed from the mouth, and delivering a tidal volume of 700 to 1,000 mils by mouth to mouth, mouth to nose, mouth to stoma, etc., at a ratio of 30 compressions to 2 breaths. Alternative airways such as LMAs or endotracheal tubes are acceptable, and the preferred airway with skilled personnel is the tracheal tube. With the airway secured, the respiratory rate is decreased to 8 to 10 breaths per minute. No more than 10 seconds should be allowed for intubation. Delivery of transtracheal oxygen by a 14-gauge catheter using non-compliant tubing should be available in operating rooms and ICUs and should be used as necessary. These systems are set up in all UK operating rooms, and you should become familiar with them. Here is a cartoon from Morgan and McCall's textbook showing the system, which is much like the one that is in use at University of Kentucky. With respect to breathing, one component of the airway, which is frequently used in anesthesia, that is cricoid pressure, is not recommended on a routine basis for cardiopulmonary resuscitation. As I mentioned a few moments ago, a ratio of 30 compressions to 2 breaths with an unsecured airway and a respiratory rate of 8 to 10 breaths per minute with a secured airway during compressions is now recommended. While compressions are more important than ventilation in the current set of guidelines, it does suggest that an increase in minute ventilation should be considered with a return of spontaneous circulation. As an aside, I find no mention of PEEP, and that should not be too surprising, as it is an adjunct, an option, and there is no suggestion or consideration of the use of PEEP, and this is in keeping with the concerns that there are with respect to intrathoracic pressure and venous return. Moving on to circulation. As I mentioned a few moments ago, circulation now takes precedence over the airway. And it is recommended that healthcare workers should check for a pulse, although laypersons should not. And I think that you should be aware of the fact that venous pulsations can be perceived as arterial when there's in fact poor arterial pressure. The compression rate is now recommended to be 100 per minute with equal time for compression and relaxation. This is referred to as hard and fast. The recommended compression depth in an adult is 5 centimeters, in children 2 to 4 centimeters. The sternum should be allowed to return to its normal position. The technique involves locking of the elbows, keeping the arms straight, and using the weight of the body to compress the sternum. The most recent guidelines recommend monitoring of the circulation when by using the arterial diastolic pressure when there are arterial lines in place, and aiming for a minimum of 20 millimeters of diastolic pressure. 20 millimeters of diastolic pressure corresponds to good quality circulation. Also, there's emphasis on the measurement of end-tidal CO2, and a value of more than 10 millimeters of mercury indicates good quality chest compression. The saturation of the venous blood in the superior vena cava, or central circulation, as sampled from a jugular vein, can predict outcome, and a saturation of less than 30% is associated with a poor outcome. Therefore, the target is to achieve at least 30% saturation. I should remind you that that even with good cardiac compressions, the output that is achieved is typically about 1/3 of a normal cardiac output. Moving along to defibrillation, it should be known that the chances for successful defibrillation and ultimate survival decline 7 to 10% per minute of delay. Therefore, the target is to achieve defibrillation within 3 minutes of arrest. This requires activation of the emergency response system and good CPR while the equipment is being prepared. The guidelines recommend the use of disposable gel pads and allow for the placement in any of the 4 recommended positions. Some attempt at preparation of the skin, either by hair removal using tape or whatever means possible, is recommended in order to minimize impedance. Referring to the guidelines, it appears that automatic external defibrillators employ the right infraclavicular and left lateral positions for the pads, and this is the recommended location for pads for AEDs. Since the dose of energy will vary from manufacturer to manufacturer, guidelines can only recommend that the manufacturer's range of energy should be followed when defibrillating. As time is of the essence, current guidelines recommend that defibrillation occur and immediate return to compressions follow, and that 5 cycles of compressions take place before checking for a pulse. Guidelines and expert references also emphasize that should the patient begin to move, that compressions be continued, because waiting for the patient to stop moving is a setup for failure. Stacking of shocks is no longer recommended, and a single shock is currently recommended because of more rapid return to external compressions. However, some AEDs may still be programmed to deliver 3 shocks. This concludes part 1 of cardiopulmonary resuscitation, and I thank you for your